right, so welcome everyone to our monthly lecture series. Just a few introductory slides. The recent symposium on fetal and pregnancy development, fundamental discovery, the recording is available at our website, and many thanks to Dr. Virginia Wynn and the organizing committee for a really wonderfully attended and interesting symposium focused on basic science. Our spring seed grant cycle has closed. The awardees will be notified by June 6, 2023, and the funding will start earliest on July 1st. And thank you so much, Anna and team and all our reviewers for the work that you've put into this. It's very much appreciated. And just to announce that our next monthly presentation will be on June the 8th. Susan Hintz, professor of pediatrics and developmental medicine at Stanford, will be talking about reimagining high-risk infant follow-up. How can we improve outcomes for children's parents and families in California? Great. So I'd like to just give an introduction to our speaker today. Dr. Torri Metz is Vice Chair for Research and an Associate Professor of Obstetrics and Gynecology at the University of Utah Health. She is a practicing maternal fetal medicine subspecialist. Dr. Metz completed both her medical school and residency training at the University of Colorado. She then went on to complete her MFM fellowship and Master of Science in Clinical Investigation at the University of Utah. She is a member of both the Society for Maternal Fetal Medicine Clinical Document Review Panel and sits on the SMFM Board of Directors. Nationally, she has served on the American College of Obstetricians and Gynecologists Committee on Clinical Practice Guidelines for Obstetrics, and is an American board examiner for both specialty and subspecialty boards. She is the Deputy Director for Obstetrics and Gynecology in the Green Journal. She has received numerous teaching awards, including the ACOG District 8 Mentor of the Year Award and the National CREOG Award for Excellence in Resident Education. Dr. Metz has R01 funding from the National Institutes of Health to study the association between cannabis use and adverse pregnancy outcomes. She is the PI for the Utah Center MFMU Network and leads their study examining the effects of COVID-19 on serious maternal mortality and morbidity. She is also leading the NHLBI-funded 4-year longitudinal study on post-acute sequelae of SARS-CoV-2 infection on mothers and their offspring as part of the Trans-NIH Recover Consortium. Beyond all that, Dr. Metz is a dear friend and a shining light in the MFM world. And so please join me in welcoming her to the Dunlevie Monthly Lecture Series to speak on cannabis use in pregnancy and while breastfeeding, sorting through hazy evidence. Welcome, Torri. We're so happy that you're here.
Thank you so much. I really appreciate the very kind introduction, especially the personal touch. It's wonderful to see so many familiar faces. I wish I was there with you all so that we could hang out, but here we are doing the Zoom thing as per usual post-pandemic. I'm going to share my screen here. And I'm going to run through some slides, but we'll try my very best to keep this to half an hour so that we can have more of a discussion, because I can tell you that, I think that there are a lot of discussion areas when it comes to cannabis and pregnancy and while breastfeeding, and I'm hoping to just talk with you guys about what's going on in your institution and, where that sort of fits in with the evidence. I don't have any conflicts related to the content of this presentation. The learning objectives are really to define the prevalence of cannabis use in pregnancy and reported reasons for use, how to counsel women regarding the risks of cannabis use during pregnancy and while breastfeeding based on our current evidence, and then recommend and utilize available resources when counseling individuals about cannabis use. So cannabis is the most common illicit drug used in pregnancy. Yes, I know it is legalized in many places now, and it does cross the placenta. We are seeing increasing use with increasing legalization of recreational cannabis. The reported prevalence is hard to get at, and I'm going to show you some data from different sources to try to give you a sense of that. In the literature, it really ranges anywhere from 3 to 30%. If you look at data from the National Surveys of Drug Use and Health, which is, a large cross-sectional nationally representative sample, it's self-reported use, and then it was 2.4% in the past month among pregnant patients in 2002, 3.9% in 2014, 4.9% in 2016, and it is likely continuing to rise. I'm going to show you some other data suggesting that. I am highlighting at a few points in this discussion some Kaiser data, as I think it's probably especially applicable to your population in California, since this all comes from Kaiser Permanente, Northern California. This comes from Kelly Young-Wolf's group. She does a ton of work related to sort of the epidemiology of cannabis use. And really it all comes out of this database with an N of 280,000 patients. They do universal urine toxicology screening in their system. And so she has UTOX data in early pregnancy for all these patients. When they looked at that overall, there was about 5% that had positive UTOX in early pregnancy compared to a self-report of 2.5%. And this is pretty consistent with what we see across the literature. When you do biologic sampling, use is about 2 to 3 times higher than stated use. And she found that being older, being of Hispanic ethnicity, and having a lower household income were all associated with misclassification of not using cannabis, meaning patients who are older and Hispanic and had lower income were less likely to self-report. We looked at data just sort of on this thought train of looking at self-report versus biologic sampling. This is when I was in Colorado, and it was shortly after legalization of cannabis there. And what we did is we took 116 participants, and we looked in their medical record and found that 2.6% of them had reported use to healthcare provider. 6% of them reported use when we gave them a survey when they came into labor and delivery asking if they'd used cannabis in the last 30 days. And we told them we would not report that to anybody else. And then when we actually sampled their umbilical cord, we found that 10% of them had a THC metabolite that was above the clinical threshold for reporting a positive, and 22% of them had detectable THC. So we use more conservative thresholds in clinical medicine than we do in research, because there's a lot of ramifications if we misclassify somebody as having use when they don't. But really, so Colorado post legalization, as much as 1 in 5 pregnancies were exposed to cannabis. These are the more recent data that I told you that I would show you, compared to that National Survey of Drug Use and Data, looking more into the time of the COVID-19 pandemic. This is also out of that same group, Kelly Young-Wolf's group, and demonstrates that the prevalence of cannabis, which is on the y-axis there, was relatively flat actually pre-pandemic throughout that year, and then really had a little bump during the time of the initial pandemic in 2020. We obviously need to continue to watch this and see what happens. It's hard to delineate whether this is really pandemic or if this is just really ramifications of increasing legalization that we're seeing here. So a lot of people ask me, why do women use cannabis in pregnancy? There's a little bit of data out there about that. This is the survey study that I tend to highlight just because I think it is interesting data. They actually surveyed women who are participating in a WIC program, and they had it, but it was a convenient sample of 2,700 individuals. And they asked them about cannabis use. And what they found is that people who had ever used were more likely to say, yep, this 59%, oh, I did for fun or recreation. Whereas the people who had current use in pregnancy, they were much less likely to say it was for fun or recreation, much more likely to say it was helping them with depression, anxiety, stress, pain, nausea, vomiting. And so I think that this just really draws attention to the fact that most patients who are using cannabis in pregnancy are using it because they have a perceived benefit of use. And so I think that's really important as clinicians when we're talking to them to understand what that perceived benefit is and see if we can help them with safer alternatives. Again, this is back to that same California cohort of 280,000 from Kaiser Northern California. They looked at nausea and vomiting of pregnancy. And again, they do universal screening with UTOX. They also did a questionnaire about marijuana use in pregnancy. And then they looked at ICD diagnoses for nausea and vomiting of pregnancy. And they found that people who had severe nausea or mild nausea had increased odds of using cannabis during pregnancy. But again, this is cross-sectional. All it says is that there's this relationship between, right, severe nausea and cannabis use. Whether one comes before the other, we don't know. We also looked at this here using stored specimens from the New Mom to Be study. And what we found is the same, that among those who had more severe symptoms, so this is looking at the puke scale, you know, looking at symptom severity, mild, moderate, severe, looking at hours of nausea, looking at episodes of vomiting, looking at episodes of dry heaves, which makes me actually want to dry heave when I say that every time. You see that the black is the THC detected and the gray is THC undetected. And what you sort of see across here is that patients who had detectable THC metabolite in their urine all sort of had these higher levels of nausea, having episodes of vomiting, having episodes of dry heaves, and having, you know, more severe symptoms. And so I think, again, it's cross-sectional, but we definitely see a relationship between these two. I think also we're seeing an increased risk, increased use because there's increased perception of safety. These data are getting a little bit old now, but I thought was a very well done look at these data from Marian Jarlinski and her group. And again, from National Survey of Drug Use of Health, what they looked at here was perception of no risk. And so among people with no past 30-day use who were pregnant, in 2005, 3.5% of them thought there was no risk of using cannabis during pregnancy. And in 2015, 17% of them thought there was no risk. And if you look at people who have had past 30-day use who are pregnant, so people who have current use, basically, 65% of them perceive no risk to use. And so I think there is an opportunity for us to do education. So what are we going to tell people? And this is where I think this is really hard. And I think this is where it's hard for clinicians to know what to do. And that's why I say we're sorting through hazy evidence. I mean, it's a little bit of, you know, I say that a little bit of joking and intended, but like it's true. We just have a lot of mixed data here, and it's hard for clinicians to take it on and know what to tell patients. So I can start by telling you what are the problems. There are problems with a lot of the data that are out there. There's a lack of quantification and timing of exposure. There's a lot of difficulty adjusting for tobacco, other drugs, and sociodemographic factors. And there's a high reliance on self-report, which I already told you is probably underestimates by 2 to 3-fold. This is an old study, but I think interesting that from 1995, they completed a prospective cohort study, multi-center. They did structured interviews and maternal serum toxicology screens. So patients knew they were getting a tox screen, they knew they were getting a structured interview. 70% of the women with a positive THC on serum tox screen denied use in a structured interview. So, I mean, like right then they knew they were doing an interview, they knew they were going to toxicology, and they still said they weren't using cannabis. These are the problems, the other problems with the studies. It's the drug that was used previously when a lot of these studies were done is old news. So, I mean, the amount of cannabis now in products is much higher. The ways people that are consuming cannabis products is different. A lot of the studies are from the 80s and 90s, and that's where all of these pictures come from. And things are different now, although I feel that some of this is coming back around. So we'll see. Just for sake of keeping this within 30 minutes, I'm not going to go through a detail of all the studies that are out there. I'm going to highlight a couple of systematic reviews and meta-analyses. And then if there's certain things you guys want to talk in more detail about during Q&A, I'm happy to do that. So there were a couple of meta-analyses that came out in 2016 that were both very nice. There's been like 1 zillion since then, okay? But I think these were both published in the OB literature, and I think are nice for that reason. So this one is a GUN meta-analysis, systematic review and meta-analysis. They looked at primary outcomes of maternal, fetal, neonatal up to 6 weeks postpartum after cannabis exposure. So basically like broad catchment, whatever we can find, 3 or more studies available, the same outcome, we're going to do a meta. And basically they found an increased odds in anemia, low birth weight, NICU admission. And they said, geez, more studies are needed. These studies aren't really as high quality as we thought they would be, and we can't really combine them in the way we wanted to. This is a study that was published by Shane O'Connor and colleagues. They did a systematic review and meta-analysis. Their aim was to estimate if marijuana use increases risk of adverse neonatal outcomes. And their primary outcomes were more well delineated, low birth weight, and preterm birth. And then they had a bunch of secondary outcomes they were also interested in. They found 31 high quality studies total that they wanted to include. 12 were low birth weight and 14 preterm birth. And in their pooled unadjusted data, they demonstrated an association between cannabis use and low birth weight and preterm birth. And you can see the absolute values and relative risks there. But after they adjusted for tobacco and other confounders, they said there was no longer an association with a pooled relative risk that was near 1 and a confidence interval that crossed 1. And they actually concluded, maybe we should direct our efforts elsewhere. They did, however, also do a planned sub-analysis of moderate to heavy use, defined as at least once per week. And in this, cannabis use was associated with low birth weight, and cannabis use was associated with preterm birth. And these are the data that are quoted in the current ACOG committee opinion on cannabis use in pregnancy. And they have put out, ACOG has put out some other patient education documents recently, but they haven't updated this recently. This was in 2016. So we went in and actually summarized a lot of the data that exists and wrote a clinical expert series on this. So if you really want to delve into more detail, I put this in here for reference. It was published in the Green Journal. And this is one of the figures from there that said, look at, these are the metas that are out there that have been recent at the time. And what you can see is that a lot of these confidence intervals do cross 1. So in this forest plot, a lot of these just kind of are here crossing this 1. And so, those would be non-significant results. I think it's also notable, though, that all these are on the right side of 1, meaning that there's concern for harm, even though only some of them are reaching that threshold of significance where you see the whole confidence interval on this side. On these, the gun meta is in silver and the Connor one is in blue. And you do see a significant difference in birth weight, which is here. We're not crossing 0 here, which would be the non-significant result in this type of picture. And so we do see a decrease in birth weight that was consistent across these studies. And I do think it's consistent across a number of the studies of cannabis use in pregnancy. This is a terrible slide because it's not readable. I tried to convert it last night to like a more readable version, but mostly I just want you guys to know that there is a JAMA open network that came meta that came out in 2022. That is another more recent meta-analysis, includes many of the other metas that are out there and that I've already covered. And what they demonstrate is that there was a higher risk of low birth weight here, this top panel, in patients who use marijuana. There was a higher risk of small for gestational age. And then here's preterm delivery. And you can see that when they summarize their data, a little bit higher risk of preterm delivery. So that's a more recent meta-analysis as well, that I just wanted to let you know is out there. And this is NICU admission. Similarly, increased risk among patients who use marijuana. So what about stillbirth? Stillbirth data are a little more limited. There's a large case control study that was completed by the NICHD Stillbirth Collaborative Research Network, and they did a secondary analysis on that group of patients and found an association between stillbirth and cannabis use, as demonstrated by a cord homogenate being positive for THC. So in this study, they did actually do an analysis for metabolite in the cord, and they did find an association between stillbirth and cannabis use. After they adjusted for cotinine in the maternal serum to account for tobacco use, it did reduce the stillbirth odds ratio for cannabis by about 10%, but this is still a pretty notable odds ratio. It's hard to say about stillbirth. As you guys know, most of the beginning of methods sections for OB studies says, we excluded stillbirths. And so we just don't have as much information about stillbirths unless that's the primary focus. But this is a study where they did do biologic sampling and did find an association. Congenital anomalies, same thing. Data are limited and mixed. There's an old study from the 80s. Again, a lot of the primary literature related to this is 80s and 90s. They did not find an association with major malformation in that study. The issue, is that this is large retrospective cohort studies that are based on birth defects registries. We can definitely get incomplete ascertainment of confounding factors and potential for recall bias, right? This is, the medical school epidemiology class, perfect example of recall bias. You talk to somebody 2 years after they have had a baby that had a heart defect. They've been racking their brains as to what they did during pregnancy to have the baby with a heart defect. And then you ask them if they ever had, cannabis exposure in pregnancy. And they're like, yes, because they thought about that time that they walked through a parking lot and it was before the football game and everybody was using cannabis and they had exposure. And then you ask somebody whose baby's like perfectly fine 2 years later if they had any exposure, and they say no, even though, they used cannabis heavily through the first trimester and then stopped. And so I think, that's inherent. It doesn't mean these are bad studies. It just means there's limitations to them. There is a nice study from the Atlanta Birth Defects Registry where they really did try to control for a lot of these confounders that are there, at least in comparison to a lot of the other studies that are out there related to congenital birth defects and cannabis use. And in this study, they found 122 cases of VSD and 3,000 controls. They did adjust for maternal age, race, overt diabetes, and vitamin use. And they found periconceptual cannabis was associated with VSD. I think appropriately, they said more data are needed. I don't think right now we have adequate evidence of an association with any specific congenital birth defect in cannabis use, but this is an area that I think is ripe for further investigation. So what about neurodevelopment? This is the other thing that I think people really worry about when we think about cannabis use in pregnancy. There are alterations in neurotransmitters in rat models, especially in dopaminergic pathways. There's a nice study that looked at postmortem human fetal brains after elective terminations, and they found that dopamine receptors are reduced in cannabis-exposed fetuses. It's most prominent in males. And interestingly, it's directly correlated with the amount of reported cannabis use during pregnancy. There are 3 major longitudinal studies looking at neurodevelopment and cannabis exposure. One is the Ottawa study. There's MHPCD, which was done in Pittsburgh, and the Generation R study. And I'm going to show you a little bit of data from ABCD, which is a contemporary cohort that I'm sure you all are aware of that's starting to publish on this as well. These are different patient populations, which I think is important for you to note. The Ottawa one is low risk European American middle class. MHPDC is much more high risk mixed ethnicity, but predominantly African American. And then Generation R is multi-ethnic, higher socioeconomic study out of the Netherlands. So what's hard about these neurodevelopment studies? They are limited by confounding. They are. And, some of, these studies have been well done. They've tried to do as much as they can about that, but it's just hard when you're looking at an in utero exposure and then trying to see outcomes that are 4, 7, 10, 12, 14 years down the road, when there's a lot of other things, obviously, that have happened in that child's life from the time they're born until that outcome measurement. In Ottawa study, they said no differences between groups below age 4 years. At age 4 years, they started to see increased behavioral problems, worse language comprehension, decreased sustained attention and memory. And then in the MHPCD study, they saw decreased verbal reasoning at age 6, worse academic performance at age 10, and increased substance use at age 14.
Torri?
Yeah.
Can I just ask a quick question?
Of course.
And also nice to see you.
Hi.
I assume that those kids probably had continued secondhand exposure to cannabis.
Yeah. And that's that's what I mean. Like, I think that that's the thing that's really hard. They do adjust for ongoing parental substance use, but, they're not like putting a monitor in the home and seeing how much is actually exposed. And so I think that's what's a criticism of this. And I'm going to talk to you about a National Academies of Science report where basically they said, like, who knows? We can't account for these home environments at all to the degree that we need to be able to eliminate that confounding that's there. Generation R, they saw higher aggression in cannabis exposed girls, but not boys. No difference in behavior at 3 years of age, and ongoing follow-up into adulthood for children born from 2002 to 2006. So this was the ABCD study that I mentioned. So this is a large study of active study network. I think we're going to be seeing a lot more out of this study network. This is a cross-sectional study of 12,000 children. They found that about 6% were exposed to cannabis prenatally, which I think is about right. My guess is that it's in the 6 to 8% range nationally on average, based on all the data that we have. Mean age at follow-up 10 years, and they found that cannabis exposure after maternal knowledge of pregnancy was associated with greater psychotic-like experiences and externalizing attention, thought, and social problems. So there is a National Academy of Sciences report, which I also wanted to mention because this is free online. If you have an interest in this, just Google Committee on Health Effects of Marijuana and it'll come up. You can download it. There's a whole chapter on pregnancy. But the summary is that they saw a consistent association between prenatal cannabis use and lower birth weight in the offspring, limited evidence of an association between cannabis use and NICU admission, And they said insufficient evidence of an association between cannabis use and neurocognitive outcomes because you cannot adjust for all of these environmental differences adequately, they felt, which is fair. So what does ACOG say? ACOG says women should not use marijuana during pregnancy or while lactating. OBGYN should not prescribe for medicinal purposes to pregnant or lactating women. And there's insufficient evidence for the effects on the nursing infant. How are we doing given all of these data? Not well is the answer. This is actually a super interesting study. It's getting kind of old because it was 2016, but I still love to talk about it because they actually recorded actual patient encounters and evaluated obstetric provider responses to disclosure of cannabis use. 19% of patients in this population reported use of their OB intake. So high risk population, high prevalence of use. 47 different healthcare providers, and 48% of the time the provider did not even respond to the disclosure. Like, move to the next question. Do you use marijuana? Yes, I do. Do you use tobacco? So there was absolutely no response. And when there was a response, it really focused on, it was non-specific, focused on tox screen, social services, punitive things, rather than trying to create a therapeutic alliance with the patient. They said things like, you know how it alters your mind when you have it, how it makes you feel. So think about what it's doing to the baby that's not even formed quite yet. It gets the effects as well. And we don't want to do that to the baby. I don't know. Do we want to do that to baby? I think this is just not a helpful conversation at all to have with the patient who is using cannabis, to find out why and talk them through risks. We did a mystery shopper study just to demonstrate that people are telling them about cannabis use if we're not, so we can't ignore our opportunities. We called 400 randomly selected dispensaries in Colorado. The caller was 8 weeks pregnant with nausea. 70% had product recommendations, predominantly recommended edibles. 65% based recommendation on personal opinion, and only 32% recommended discussion with the healthcare provider. So somebody's talking to these patients. This actually had a huge public health impact in Colorado and made that end up being the biggest public impact I have of all the things that I'm doing, which is funny because this was a resident research project. So talking about marijuana use with patients, there are online materials. These are online materials from the Colorado Department of Public Health and Environment. There are ones from ACOG that I tried to screenshot the PDF of, but for some reason it will not let me. I don't know if ACOG has some kind of block on it. But if you go to the ACOG website and just search for cannabis and pregnancy or marijuana and pregnancy, it'll pop up. It's actually a relatively new infographic that is intended for direct to patient counseling. All right, super briefly. And because there's only brief information in the next 5 minutes, and I'll have time for discussion. Breastfeeding. THC metabolite does pass to the neonate in breast milk. There is a letter to the editor that was in the New England Journal of Medicine, 1982, of 2 patients that talked about chronic heavy use that can result in levels up to 8 times in plasma. That is 1 patient. And so I think that I just say this because I hear this quoted all the time. It's not a scientific study. It's a letter to the editor. It is literally 1 patient that they found this in. And so I think we just need better data. There's a little bit better data. Observational study of 8 women who purchased a product with known concentration of THC at a Colorado dispensary. They abstained from use for 24 hours prior, and then they inhaled cannabis, collected their breast milk at 20 minutes, 1, 2, and 4 hours. And they found that an exclusively breastfed infant ingests a mean of 2.5% of maternal dose. So this is, limitations, right? Go buy this product, get really high, try to collect samples when we tell you to and send them to us. There's some issues that could have occurred. This is another study, 54 samples from milk donors. 63% of the samples up to 6 days after last reported use had detectable metabolite, median concentration of 9 nanograms per ml. Not surprisingly, the number of daily uses and the time from sample collection to analysis were predictors of concentration in the breast milk, right? Just like everything else, as you would expect. We did a prospective cohort study that was published in JAMA Peds, looking at the time to elimination from marijuana metabolite from breast milk. So 25 patients. The inclusion criterion was planned for abstinence. So we found, though, that only 12 of the 25 who said, absolutely, I'm going to be abstinent, could be abstinent. So I think that honestly is one of the most important findings potentially. And then we looked at how long the metabolite persisted in the breast milk. These patients had primarily inhalation consumption during pregnancy more than twice a week. And they all had detectable THC in breast milk in all participants, including those who abstained over the whole 6-week study period. Now, that does not mean that the infant is experiencing effects of that. We don't know what that means, how much of it is ingested in the gut. We weren't able to sample the neonates for a number of reasons, but we couldn't. So all we can say is still in the breast milk. So basically we looked at 402 samples across these 25 patients. The half-life was about 17 days. Projected elimination is over 6 weeks. So we cannot tell patients they can pump and dump. And I think this is important because I don't think that's a reasonable solution for patients. And it is something that sometimes gets suggested. Why don't you just tell her to pump and dump? Well, that's not going to work in this case. So that's not going to be a viable alternative. And so we just need to talk through patients and risks and benefits. So what do we tell patients? There's not any known benefits of cannabis use in pregnancy. There are possible risks. We need to advise patients not to use it during pregnancy, and that there's no safe amount in cannabis and while breastfeeding. There are a lot of studies that I did that I talked about here that are supported by a number of grants, which are here. And there's my email, because I realize this is a whirlwind tour. So I do want to open it up for questions and just conversation with you guys in the last like 12 minutes here to talk about the issues you're dealing with, put those in the space of data as much as we can. But I know that this is a short talk for a really broad topic. So I wanted to make sure to get my email up there as well. So I'm going to stop sharing. And I would love to hear what you guys are thinking about, what you're encountering, what will be helpful to talk about besides just kind of the broad overview of the data.
Torri, thank you so much for this talk. Yes, it was a broad topic, but you hit so many wonderful granular points for us and very, very informative. I have a couple of questions, but I'll hold off for now and see whether there's anyone in the audience who has a question.
I see a scary in the chat. I don't know when that was to. Oh, maybe it doesn't get eliminated for 6 weeks.
That was Dr. Michelle Kahn, and she was, I think, referring to your secret shopper project and the
yes, the secret shopper project is scary. I agree. It would actually be interesting to repeat it in Colorado now. In my spare time. But I think that it's, because the dispensary's gotten a lot of trouble when we published that. It made national news, and they are not supposed to be giving any kind of medical advice. And they're basically offering medical advice to somebody who is calling with a medical complaint. And so that there's a huge education push in Colorado after that. I'll bet if we called now, we would get a different story. I see Deirdre's question. What is the effect of secondary smoke? That is harder to sort out for cannabis than it is for tobacco. And that's because there's really well-established cotinine levels for sort of active versus passive exposure in terms of biologic sampling. And so, and then we don't have the same kind of thresholds for biologic sampling for cannabis metabolites. We can sort of infer that people only had secondary exposure, and we did collect some data about secondhand exposure with one of the studies that we did in Colorado that we had urine samples for, but we just didn't have enough of it to really delve into it. Presumably if it's inhalational, right, you are certainly getting some exposure. It's going to be less than active exposure, similar to tobacco. But I think the reason you don't see more about that in the literature is because those thresholds are not well delineated in the biochemistry world in terms of lab assays.
Torri, are you seeing any regional, and you may have touched on this and I might have missed it, are you seeing any regional differences in the use of cannabis in pregnancy?
There definitely are regional differences in use, but I think that until, so we actually did a study in Utah where we did sampling of cord segments across randomly selected cord segments across all the hospitals in the state of Utah. And we definitely found hotspots for different types of substance use. But I think that doing that sort of sampling is really the only way to really get at it, just because there's so much underreport of use when we rely on self-report that I just don't know that the data are especially valid without doing some kind of biologic sampling. Now, I am not suggesting that every pregnant person has a U-Tox. Like, I don't think that's the answer. I think every pregnant person should be screened for substance use. And then if they tell us they're using substances, then we should talk to them about it instead of ignoring it, like in the Holland study. But, and from a research perspective and an epidemiologic perspective, if we really want to classify correctly people who are using cannabis or other drugs, it really has to be by biologic sampling. There's just such a societal pressure to say that you're not using drugs in pregnancy, that I think it's really hard to get any self-reported. Plus, people are worried about the legal ramifications of that. We did a study in Colorado. Again, a lot of these, so we just didn't have time to go through, where we looked at self-reported use after legalization in Colorado. Boom, it went right up immediately after legalization. And then as soon as people found out that they were still getting reported to CPS because it's still Schedule 1, it went right back down. So I think, you know, if you can get people into a safe environment, you can probably get at self-reported use. But without sort of all these other ramifications, legal barriers, self-reporting, blah, 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 you're just never going to get out it without biologic sampling in terms of true prevalence. I think the true prevalence is about 7 to 8% if you look nationally.
Great, thank you. I had to switch to my phone because something happened on my computer. My apologies.
No worries.
Michelle, you have a question? Go ahead.
Yeah, hi, Michelle Kahn. I'm one of the generalist OBGYNs.
Hi.
Thanks for your talk. That was really interesting. I had a couple of questions. One is, given all this data, like what would be like a good, like overall way to counsel patients about THC use and the possible impact on the neonate or baby? And then the second question is, I've heard talks about this in the past and heard that babies that are exposed to THC might have like worse coping mechanism, might be more fussy, and I don't know if I missed that, if you've seen anything on that data.
Yeah, thanks for both those questions. So in terms of, you know, just practical clinical advice, like what am I going to tell my patient? What I typically tell them is, first of all, I'm honest with them and I'm like, we don't have all the answers about cannabis in pregnancy, but we do think there's risks. I think it's pretty well delineated that there's a decrement in fetal growth. I mean, that is consistent across numerous studies. It's consistent in meta-analyses. It's consistent in the national academies. And so I tell them, you know, it looks like it affects fetal growth, which makes sense because, you know, the endocannabinoid system is very active in placental implantation and formation. And so I do think there's biologic plausibility for that. We actually see that in non-human primates as well when they're given cannabis in a controlled setting without all these confounders. So I think that's true. The other stuff I think is softer. I talked to them about there may be an increased risk of stillbirth. There's a study that I talked to you guys about, but that data is pretty limited. There's potentially an increased risk of NICU admission. I think that data is still evolving. And that we worry about neurodevelopment. Like we know that cannabis crosses the placenta. We know that it interacts with a lot of the receptors that are happening in terms of neurodevelopment. And, you know, why are they using? I mean, I think that's the most important question. And usually I can tell you it's anxiety, depression. I think it makes my nausea better. And so then I just talk to them about, you know, can we try some of these other alternatives? And, you know, sometimes they will and sometimes they won't. Like ultimately it's their choice, of course. I just think that we just need to give some information. I think breastfeeding is trickier. We can go into that. I think, you know, from a breastfeeding perspective, that is a hot button issue. Many places, I don't know what you guys do there. But, you know, I think it's hot button because I think a lot of places that, especially when you're not able to breastfeed yourself and you're giving milk to NICU babies or things like that, that's where it gets a little tricky. I don't think that we can pump and dump. I think it hangs around for a long time. I think the absolute amount that's transferred is exceedingly small. I think there's numerous advantages to breastfeeding. I think we should tell patients to stop, but I don't think we should withhold lactation support if they are using. The data just aren't there to do it. And then in terms of the withdrawal, there are a couple of like small, like control case, almost more like case series looking at neonatal withdrawal from cannabis, irritation, jitteriness. I don't feel like that's totally well described at this point. I do think it's an area for future research. I have not seen anything very recently on that. Most of that is old data describing that. And I see Elliot's question, given poor response to direct inquiry, is it better try and educate every pregnant person about risks of cannabis and tobacco? Yes. I mean, I think if we can, absolutely. I mean, I think every patient should be screened. You know, we can there are certainly patient handouts and things available that we can at least hand out and say, hey, we recommend you don't do this. And maybe that's going to spark a conversation like, oh, I didn't know that I shouldn't maybe do that. But definitely when they tell us, and they do tell us a fair amount, even in a state that doesn't have recreational legalization like Utah, I think we just need to talk to them about it. Brendan.
Hi, sorry, I don't have my video on. Great talk, by the way, really interesting. I'm the only anesthesiologist on this call. So the question I have for you is, if someone asks, can I use it for labor pain relief? What would you tell them?
I am aware of zero data where people have actually done that. Given the smell in the room, maybe sometimes they are, I don't know. But I do not think there are any data about that. People do say they use it for pain. But again, like the efficacy of it for pain, certainly in labor, I would say is complete black box. No one knows.
And if the obstetrician asks to use it during labor? No, I'm just kidding.
Well, I mean, yeah.
Dr. Metz, I had a question. I'm Stephanie Leonard. I'm an MFM faculty epidemiologist. I had a question about the method of intake. I thought it was interesting, like in your dispensary data, they suggested edibles, which I'm guessing is because we've successfully had a public health message that smoking is bad, but not that cannabis or THC are bad. I mean, what are your takes or what's your impression?
Yeah, I mean, that is a good question. I think it's also potentially that like edibles were such a big thing when cannabis became recreationally legalized in Colorado. And that's kind of when we did that study. I mean, everybody went to the dispensaries for edibles. I mean, if they were going to smoke, they just like got it the way they normally did. Whereas these edible products were all the rage. And really, there was a lot of tourism around edible products. People would come to Colorado to get their marijuana edibles from the dispensary. They'd get their special ones that like, depending on what they wanted from the edible. So my guess is that's partly it, but you're right. It could also be partly that they think maybe inhalation is bad. We did not ask them why they recommended edibles. We just asked them what they would recommend.
But do you think that there's any difference for safety or in regard to method of intake?
Zero data. When we looked at mode of intake in a group of people who use cannabis that we followed longitudinally in Colorado, still like 80% of them were smoking. I think it's cheaper. I think it's more available. But there are no data looking at one versus the other. I mean, you are going to get like some more first pass metabolism with edibles, obviously, compared to inhalation. But it's still the same metabolite. You know, it's still going to go into the bloodstream. I think you're still going to see similar effects on the placenta for that reason. But nobody has really sorted out by mode. This is a challenging area to research, as you can imagine, because there's, you know, you obviously don't want to create problems for patients because you've collected data about them for research perspective. So like my RO1 is like all de-identified urine samples, and that's kind of the way to do it. But then it makes it hard. Like I can't go back and be like, oh, were you smoking or were you using it another way? Then it's the same. The metabolite looks the same on the other end in the urine.
Torri, thank you so much. This has been so educational for all of us, and we're just so grateful for you to join us. And I hope you'll consider joining us again for other talks. But it was wonderful, and Virginia says awesome talk, and I think we all agree.
Oh, thank you. Thank you all. Virginia knew me when I was medical student resident. So thank you all for joining. Really appreciate it.
We've
Thank you,
published
Torri.
together.
We have published together. It's true.
Uterine torsion.
A case report.
Yeah.
See, I remembered. All right. Thank you.
Thank you. Take
All right.
good care.
You.
Bye all.
Bye now.
Great talk.